Okay, can you see my screen okay? Okay, perfect. Well, hello everybody. Thank you for inviting me to be here. My name is Brian Hobeck. I am with the South Dakota Department of Health. I am the Heart Disease and Stroke Prevention Program Coordinator. I also have worked several years. I'm a nurse by background, worked several years at Avera McKinnon in the neuro ICU, and within that role, I was also on the stroke team. So I love to talk about stroke prevention and awareness and treatment. So I'll do my best to keep it on track today. So just a few objectives, hope to get past today, stroke epidemiology, anatomy of a stroke, as well as stroke care and treatment options. So just want to start off by talking about stroke statistics. I know that as professionals working in healthcare settings, there is a lot of issues that we need to address and tackles, and there's a lot of barriers and challenges, especially with us living in such a rural state. So just want to talk about why it is important to talk about stroke. So stroke is the seventh leading cause of death in South Dakota, and it has been for several years. It is also the leading cause of disability. And something I'm going to talk a lot about today is the how we respond to stroke is directly correlated with a patient's outcome. So the faster that the patient can get to the hospital and get treatment, they're gonna have a better outcome. You've probably heard time equals brain. And a lot of that comes from awareness as well. We know there's a deficit in the knowledge for stroke. Many people, they know the basic stroke symptoms, but there's a lot of symptoms that can be a stroke. So just that awareness piece as well is very important. Another important issue of stroke is that it's largely preventable. About 80% of strokes are thought to be prevented. So we're going to talk a little bit about risk factors as well. So stroke anatomy. So to summarize, stroke is a lack of blood flow to an area of the brain. It can be further categorized into ischemic and hemorrhagic. It's important to note that symptoms of ischemic and hemorrhagic strokes can look very similar, but the treatment is very different. In fact, it's quite the opposite of each other. And the only way we really know what type of stroke that patient is having and how we should treat that patient is with imaging. So if you see my little picture here in the corner, so ischemic stroke, is most often by blood clots. It can also be caused by buildup of plaque or cholesterol in a vessel. And then hemorrhagic stroke is where a vessel starts bleeding and you have bleeding into your brain. So to get a little bit more in depth on ischemic stroke, so ischemic strokes, like I had mentioned on the previous slide, it is due to a blood clot or buildup of plaque is most commonly the reason. This is the most common type of stroke. Ischemic strokes account for 87% of stroke cases. And then I also put TIAs or transient ischemic attacks, or also called mini strokes, here on this slide as well. So this is when somebody has stroke symptoms and these symptoms resolve within 24 hours. Oftentimes in TIAs or mini strokes, these stroke symptoms resolve even quicker than that. Sometimes it is only a half hour to an hour, and sometimes it's only a few minutes that a patient's having stroke symptoms, and then these symptoms resolve. Even though that the symptoms resolve and there's no permanent brain damage with mini strokes, it's important to know that those should be treated as a medical emergency. So if someone starts having, weakness in their arm, for example, but it only lasts a few minutes and then it goes away, if they're at high risk for a stroke, we really should work them up. They should still go to the hospital. This is still considered to be a medical emergency. These patients are very high risk for having a real stroke, and in fact, about 25% of people with TIAs or mini strokes will go on to have a stroke within 6 months. So very important that we continue the workup and look at the patient's individualized risk factors so that we can prevent a stroke in the future. So kind of switching lanes here and looking at hemorrhagic stroke a little bit further. So like in that picture, it's just a rupture of a vessel. It's bleeding into the brain. There is two different types here. Intracerebral hemorrhage. So this is bleeding from a vessel within the brain. And then you also have aneurysmal subarachnoid hemorrhages. So an aneurysm rupture is also considered to be a stroke. And this is bleeding from a ruptured aneurysm. So the biggest difference between intracerebral hemorrhages and aneurysmal subarachnoid hemorrhages is just different layers here in the brain. And I should have a picture here on this next slide. Yeah. So as you can see, the two on the bottom is intracerebral hemorrhage and then subarachnoid hemorrhage. So you can kind of see they're just in different areas of the brain. So there's different treatment options for that. And then I also wanted to point out that not all brain bleeds are considered strokes. So although we consider intracerebral hemorrhages and subarachnoid hemorrhages to be stroke, we have these two on the top, the epidural hematoma and the subdural hematoma on the top. Those are most often caused from trauma or blows to the head or falls. So they aren't necessarily considered strokes. So I wanted to make sure that we talk about risk factors today. So lots of different risk factors for strokes. Blood pressure is thought to be the biggest risk factor when it comes to stroke. An estimated 50% of the adults in US are thought to have high blood pressure, but only about 25% are aware. Cholesterol is another risk factor, as well as atrial fibrillation, that irregular heartbeat. Something I like to point out with these three is that a lot of times patients don't have symptoms of these. A lot of patients don't have symptoms of high blood pressure or high cholesterol or atrial fibrillation. So these can go undetected if a patient's not seeking regular medical care. And the other thing too, I should point out with atrial fibrillation is it can be sometimes very tricky to catch. Sometimes patients only flip into that irregular heart rhythm for a few minutes at a time, and then they flip back into normal sinus rhythm. So not all patients are in atrial fibrillation all the time, but it's really, really high risk for stroke. So a lot of times when we see patients in the hospital and we suspect that they might have atrial fibrillation, we might discharge them with a longer term monitor at home and then have them follow up with their doctor. So a few other risk factors for stroke is if you've ever had a previous stroke or a TIA, like I mentioned before, you're at very high risk for having another stroke. Smoking puts you at high risk for stroke, obesity, age. Unfortunately, there's not much we can do about age, but as you get older, you are more at risk for having a stroke, as well as gender. Males are just a tad bit higher risk for having a stroke, although females tend to have more devastating strokes. So I'm sure you've all seen this. It's the BFAST acronym for spotting a stroke. You may have also seen the FAST acronym. So the FAST has been expanded in the last few years to BFAST, just to account for a few other symptoms that were leading to missed strokes. So just to talk about this a little more, because B is for balance. So if you encounter a patient that is they can't walk in a straight line, they have dizziness or vertigo, this can be a sign of a stroke. Eyes, if you have blurry vision, double vision, sometimes patients having a stroke can have field cuts where they might not be able to see out their central vision, or they might not be able to see out of their peripheral vision. This is also considered to be signs of a stroke. F is for facial drooping. A is for arm or leg weakness. S is for speech difficulty. This can manifest itself in many different ways. You might have a patient that just has a little bit of slurred speech, and it's kind of hard to catch, but you can kind of tell they're not talking right, or maybe a family member says, oh, they don't sound like they normally do. That can be a sign of a stroke. But also speech difficulties can manifest itself as a patient can't get their words out, or they're not responding appropriately. You ask them their name and they say it's fish. They're not getting the right words out. And it also can manifest itself as they can't comprehend, depending where the patient's having the stroke at, sometimes it affects their language center in their brain, so they can't even comprehend what you're saying to them. So you might be talking to them and asking them a simple question such as, where do you live? And they're just looking at you with a blank stare. Their brain is just not processing what you're saying to them. So there's many different ways that can show up in different strokes. T is for time. So we like I said, time equals brain. If they've called most likely they've called 911 if you're already there. But it's time to get them to the hospital immediately. So now we're going to talk a little bit more about stroke symptoms more in depth for the different types of strokes. So a stroke in the right side of the brain, you may already know that it's going to cause left-sided weakness. It can also cause left-sided neglect and speech difficulties. And then something else that I always think that's interesting is it can cause right gaze preference or deviation. So I'm going to flip over to the next slide real quick and then I will come back. So this is what we call a gaze deviation, and it's very common in ischemic strokes. And so if a patient's having a stroke on the right side of their brain, they're going to have left-sided weakness, but they can have gaze deviation towards the side of their brain that they're having the stroke on. So even though they might have left-side weakness, their head is turned over to the right and their eyes are fixed over to the right side of their body. And you might be on their left side, talking to them on their left side, but they're not looking at you. They might be ignoring you completely. They're not recognizing that left side of their body as theirs. So they're not looking over that way. It's like they're looking out a window out to that side of the body. So that can happen whether they're having a stroke on the right side of the body or the left side of the body. And then in the stroke in the left side of the brain, that's going to cause right-sided weakness, can also cause speech difficulties, and it can cause, if they're having a stroke on the left side of the brain, it can cause that left gaze deviation towards the left side of their body. It's important to note that if a patient's having a stroke, they're not going to have all these symptoms. They might not have any of these symptoms. Strokes really just can vary from person to person, and it depends on where that stroke is happening at in their brain. So I also wanted to touch on ischemic strokes that are happening in the back of the brain. So this is when strokes affect that anterior circulation of the back of the brain. So these cause more atypical, I would say, symptoms. They can cause that dizziness, vertigo, blurry or double vision. They might have difficulty with coordination. They might not have any hand-eye coordination. And then another symptom of posterior stroke is abnormal eye movement. So the patient might have their head still, but their eyes are darting back and forth. It's almost like they're shaking in their head. Something that's really important to note with these is these might not always come across as common stroke symptoms, so they can be missed. And a big thing that we do see is these strokes are kind of written off as maybe a patient's intoxicated or under the influence of some type of drug or alcohol, just because if you look at these symptoms, that can all kind of match up with being under the influence. But it is important to note that these are stroke symptoms and it should be taken seriously and a patient should get worked up. So kind of going over into that hemorrhagic lane a little bit. So signs and symptoms of intracerebral hemorrhage. If you think about it, your skull is a closed capsule. There's not much room for anything more, and your skull can't expand on its own. So if there's just a little bit of blood in your brain, you're going to notice that you're going to have headache, nausea, vomiting is very common in head bleeds, and as well as altered mental status. And this can kind of show up as a few different ways. They might be just a bit confused. They might be agitated. They also might be drowsy or have some, they might be lethargic as well. And then that subarachnoid hemorrhages, so these are correlated with aneurysm ruptures. Kind of a hallmark symptom of this is worst headache of my life. They might say that. We call it a thunderclap headache. Some patients even hear like a crack in their head. Headache comes on very quickly and it's very intense. They also might have some neck or pain. And then a lot of times these patients also have some altered mental status or even loss of consciousness. So pre-hospital assessments. So I'm sure you all have your policies and protocols on what you do when you encounter a patient having stroke symptoms. So this might include a BFAST exam, just kind of getting a quick summary of the symptoms they're having, vitals. Something that's really important to look at is blood sugar. A lot of times low blood sugar can mimic a stroke. So if that's something we can easily treat and the patient's back to normal, that's an easy fix. Something we do recommend is keeping the patient laying flat if they can tolerate. Obviously, some patients can't lay flat. They might be having some breathing issues, so they are not able to lay flat. But they are able to lay flat. It's thought that laying flat increases the perfusion to your brain, and so it can hopefully better a patient's outcome. IV fluid boluses are often recommended as well as interviewing. I know working in the hospital was always so helpful when EMS were able to interview maybe some witnesses or family members that were around. One of the most important things we need to ask when we treat a patient that's having a stroke is, when did the symptoms start? When was the onset of symptoms? So was this something that was witnessed? So was the patient eating supper and then all of a sudden their right arm went weak? Or um, were they talking and then all of a sudden they couldn't get their words out? So if we know that onset, that's extremely helpful when determining the treatment for a patient. We don't always know those symptom onset might not always be known. We might have patients who live alone and someone went to check on them and they're found down. Or maybe the patient went to bed at 10 o'clock and then when they got up at 6 a.m., they got up out of bed and they fell and the spouse found them. So we don't always know when those symptoms started. So the next best question we can ask is, when was a patient last seen normal? So that can kind of narrow it down a little bit. Some other important questions that we like to know right away is medication use. Now, right away, we don't need to worry about knowing what medications the patient was on. But if we can figure out if they were on any anticoagulants or blood thinners, that's very helpful to know right away. Also, if they've had any history of stroke or recent trauma or bleeding, or recent surgery, that's very helpful when determining our treatment. So hospital workup, obviously the most important thing we need to do is look the ABCs. We need to make sure the patient is stable. If we are able to, we ideally, with patients having strokes, we like to keep their oxygen saturation above percent. That's just thought to increase the oxygen perfusion in the brain and help with outcomes. We like to get the blood sugar very quickly if we haven't already. Like I said, it can mimic signs of a stroke. So if that's something we can treat right away. Vitals, I should point out that with ischemic strokes, we do allow what we call permissive hypertension for the first 24 hours after a stroke, up to 220 over 120. So that's quite high, but it's thought to allow perfusion to the brain and help with outcomes. If the patient, that's only with ischemic stroke. So if a patient is having a hemorrhagic stroke, we certainly don't want the blood pressure running that high. Other things we do initially is the NIH stroke scale. This is almost like a universal stroke scale, sorry, that we do. It just quickly looks at the stroke symptoms a patient is having. So the stroke goes anywhere from 0 up to about a 42. So the higher the number, the more symptoms or the more severe stroke the patient is having. So a 0 would be no symptoms at all. But the higher you go, the worse their symptoms are. We also like to quickly do a large vessel occlusion assessment. I'll get into that a little bit more, but a large vessel, if a patient's having a large vessel occlusion, that might mean they're a candidate to go to the cath lab for a thrombectomy. So we want to assess that. There's some very specific symptoms that go along with that large vessel occlusion assessment. And then right away, as long as we kind of do everything else and the patient's stable, we take them to a CT. That's initial head CT is going to look for any brain bleeds or maybe other things that are happening in the brain that are causing signs and symptoms of a stroke. Sometimes a brain mass, or we find a brain lesion or a brain tumor that's causing those symptoms. So right away we do that regular head CT. If that head CT is clear, we treat it as an ischemic stroke. You cannot see strokes on a CT until after the symptoms have lasted for 24 hours. So if a stroke is a new stroke, it's less than 24 hours old, we're most likely not going to see that on a CT. So if we don't see that on a CT, we're going to treat it as an ischemic stroke and proceed with treatment that way. We also get a CT angiogram. So this is going to look at the head and neck vessels. If there's a patient that has a blood clot in one of the larger arteries in the brain, that CT angiogram is going to help us look at that. And then there's also CT perfusion scans. Now we don't do this on every patient. It's more helpful to do with patients that have a last known well that's been more than 6 hours, or maybe we don't know the last known well. The CT perfusion is a newer technology, and I don't understand completely how it works, but what it does is it looks at how much of the brain is still salvageable. So when a stroke happens and brain tissue starts to die, we can look at that CT perfusion scan and we can say, oh, there's a lot of the brain that's still salvageable, or actually, no, this stroke must have happened a long time ago. There's not a lot of salvageable brain tissue, and it's not worth doing treatment. So providers can really guide their treatment based on the CT perfusion scan if we don't know the last known well or they're questioning treatment. We also get EKGs as part of the initial workup. This is all done within 10 minutes of patient arrival to the emergency department. So we work very quickly to get that done. And the primary goal of all of this workup is to restore blood flow to minimize patient death as quick as we can. So like I mentioned, the ischemic versus hemorrhagic strokes are treated very differently. So first we're going to talk about treatment avenues for the ischemic strokes. So the most common treatment for ischemic strokes are thrombolytics. So you might have heard it as alteplase or tenecteplase. I think almost all the hospitals in South Dakota have transitioned to tenecteplase or TNK over the last few years. And this is a clot busting drug. So any blood clots in your body, this medication is going to find it and it's going to bust that up. So ideally, if a patient's having a stroke caused by a blood clot, this medication is going to break down that blood clot and restore blood flow to that area of the brain. There is a time frame that we have to give this medication. We have to give it within 3 to 4.5 hours, ideally within 3 hours of symptom onset, but there are some times we can give that up to 4.5 hours within onset of stroke symptoms. Very high risk medication, so it takes away your clotting factors in your body. So there's a lot of assessment you have to do before we can give this medication. Biggest thing is asking about blood thinners. There are certain types, so not all, just because a patient's on a blood thinner doesn't mean we can't give this medication. It depends on what blood thinner they're on. So if they're on aspirin or Plavix, which is kind of a less intense anticoagulant, they can still receive this medication, but maybe some of the stronger anticoagulants such as Eliquis or Xarelto, we wouldn't be able to give this medication. Now there is caveats to this. If the patient hasn't taken their blood thinner in 2 weeks, they would be a candidate for this clot busting medication. So there are caveats to all these contraindications. Another big contraindication that I want to talk about is any recent surgery or trauma. So if they had an abdominal surgery a week ago, they're not a candidate for this. Or if they've had any recent trauma, maybe they fell and hit their head a week ago, want to treat that very carefully. We most likely wouldn't want to give this patient this medication, or any history of recent significant bleeding, like a GI bleed or something like that. Blood pressure is another contraindication, although it's not an absolute contraindication. We have a patient that's blood pressure is running 200 over 100. We can treat that blood pressure and then give this clot busting medication, but we cannot give that until that blood pressure is more controlled. Same with blood sugar. If their blood sugar is out of range, we want to treat that very quickly. Once the blood sugar is within normal range, then we can give this clot busting medication. One protocol with this medication is the patient has to be transferred to a center that has a neurosurgeon on 24/7. So rural facilities can give this medication, and then these patients are typically shipped off to a larger hospital. Another treatment that not all ischemic strokes are a candidate for, but this thrombectomy. So this is where they take patients to a cath lab and they make a small incision in the femoral artery, or it can also be done through the radial artery, but most often it's done through the femoral artery. And a neurointerventional radiologist can thread catheters up to the brain, and then retrieve that clot and then restore blood flow. So this is considered to be the gold standard for stroke treatment if a patient is eligible. If you think about it, after our vessels in our brain, they start branching off and they get really small. Well, these catheters they're very small, but they're only so small. So it has to be in a larger vessel that these catheters can get through. So oftentimes, we do this procedure for middle cerebral artery stroke. So this is the artery that's kind of right off your carotid artery in your neck. This is a larger vessel, and if a patient's having a blood clot that's occluding that vessel, they can be taken to cath lab. This is done if the last known well is less than 24 hours. So we have a little bit more treatment time when you compare it with the thrombolytics. But the patient's going to have better outcome if they get to the cath lab sooner. So this is just an example of what they do in cath lab. So here, you're looking at dark little wiggle is the carotid artery and kind of as it branches off. So you'll see in the next picture what it should look like, but there's a clot that's kind of right in here that's blocking off blood flow. And so this patient was taken in the cath lab. And if you can kind of see on this first image on the left, especially, there's kind of a straw looking thing within the vessel. So that's the catheter that they use. And then they deploy another catheter that can go up further. So this is after the clot was removed. So you can tell that it looks a lot different. You can see the vessels and that blood flow is restored. With this patient specifically, unfortunately, this patient, I believe, was somewhere around the Huron area. I can't remember exactly where he came from, but this was from last year when we had a lot of bad snowstorms. And unfortunately, the patient's care was delayed because he couldn't fly. He couldn't get there by flights because of the weather. Also couldn't come by ground because it was one of the biggest blizzards last year. So his care was delayed by about 8 hours. So although he did have a successful procedure, they did remove that clot. His outcome wasn't the greatest just because it took him so long because of the weather to get here. I would give you a little warning here, but I think we're all used to this. But this is the clot that they pulled out for this specific patient. So I know I've touched on this quite a bit here today, but why is it so important? I just like this graphic because it really shows you why it's so important. So if you look at the first three brains on the top, you can see we call the treatable brain after a patient has a stroke as the penumbra, and the penumbra is considered to be the salvageable brain tissue. So if it's kind of the lightest pink, so that dark red here in this first image on the top left, this is where the stroke is happening in this graphic. And then this penumbra is considered to be this lighter red color. So this lighter red color is brain tissue that we can still save if the patient gets treatment. Now, as they wait to get treatment, or if they're alone or they don't seek treatment, this area is going to get larger. And then over on this third image on the top, this is going to be what happens when they don't receive treatment. They're going to lose a lot of their function in their brain. if the patient doesn't get treatment within the 24 hours, very, very high mortality rate, because this dead area of brain is going to start to swell and cause lots of issues. So if you can kind of see, this is when we get, I like to kind of jump to this bottom picture. If a patient does get treatment right away, they have a very small area of brain affected, and hopefully their symptoms are lessened. So then jumping over to our hemorrhagic strokes, unfortunately, hemorrhagic strokes don't have as many options as compared to ischemic strokes. Our biggest one is blood pressure control. We do like to keep the blood pressure a bit lower with these strokes. So ideally keeping it below 140/80, that's going to kind of lessen the bleed. These patients are under very close monitoring. Sometimes we do surgeries or we insert drains in the brain to drain that blood. I should note that surgery doesn't really help the patient's outcome. It's just going to prevent them from getting worse. And then talking about aneurysms here. So our treatment with these is we want to secure that bleeding as soon as we can. Most often these days, this is done in the cath lab as well. So the patient, they go through the femoral artery and they thread some catheters up to the brain and then they coil it. And there's a few different things they can use to secure that aneurysm. Aneurysms ruptures can also be what we can clip the aneurysm, but that's more of a surgical procedure where they have to go in and open the skull. With this coiling, that's a minimally invasive procedure where they can just kind of make a small incision in the femoral artery. These patients require very close monitoring. They're at high risk for rebleeding and complications for a few weeks after an aneurysm rupture. So they're often in the hospital. Even if they're doing really well, they're often in the hospital for 2 to 3 weeks just to keep a very close eye on them, just because they are high risk for rebleeding. So just to wrap up, despite our advances in treatment and prevention, strokes will not be going away. Stroke treatments are available, but only effective if they are administered very quickly and in a timely manner. And I just want to point out that EMS personnel are so critical to helping ensure stroke patients have access to these therapies, whether that be getting them to their rural hospital in a timely manner so so that rural hospital can start the stroke process, as well as transferring these patients to these different stroke centers. So thanks again, everyone, for having me. Love to answer any questions if anybody has any.
Feel free to throw them in the chat if you want to as well.
Yeah. Mm-hmm.
And we can get those answered.
Thank you.
Yeah.
Well, thank you so much, Brianne. We appreciate you coming on and sharing all that really great information. I do have a survey that I'll need you guys to complete. I have to find it quick. I apologize. But yeah, we appreciate all the great work that you're doing with the state and how that's helping make an impact across the state as well.
Yeah. Thanks for having me.
Thank you, everyone. Have a good evening.